This is Ileana Piña. I am a professor of medicine and the chair of quality for Thomas Jefferson University in the Division of Cardiology. My love is heart failure. For years, I have been very worried about how patients are experiencing their disease, because you may have the same ejection fraction, you may have the same NT-proBNP, but everyone experiences it differently. And it's always been my experience that women always have a lower health status with exactly the same clinical parameters, something that we don't really critically understand. So I'm very happy to have with me today Dr. Sandhu from Stanford. And his trial has to do with probably our most commonly used health outcome measure that we have today, or PRO, which stands for Patient-Reported Outcomes, which is the Kansas City Cardiomyopathy Questionnaire. They've been around since the mid-1990s. Even the FDA has approved the Kansas City Cardiomyopathy Questionnaire and the Minnesota Living with Heart Failure for presentation in CDRH, which is a device area. So I want to welcome you. Tell me about the trial that you've been presenting here at the ACC, the name of it, and why did you do it?
Thank you so much for having me. Really excited to be here to present the impact of patient-reported outcomes in heart failure clinic trial PRO-HF. The rationale behind PRO-HF is we've known for a while, as you mentioned, that patients' reports of their health status using validated structured PROs, it's often quite discordant with how clinicians capture patient health status using the New York Heart Association class. And PROs are also probably better predictors of patient outcomes than NYHA class. So based on that, the 2022 heart failure guidelines for the first time included a class 2A recommendation to start capturing this as part of care. But there's no randomized data to help us understand what does capturing that data end up doing in terms of changing how clinicians treat their patients, how it ends up changing clinical outcomes. So that's what we aim to assess in the PRO-HF trial. So in the PRO-HF trial, we randomized 1,248 participants.
That's a good number.
It was across about 5,500 eligible participants seen in the Stanford Heart Failure Clinic.
How long did it take?
It took just under 1 year of enrollment.
Oh, wow, that's a lot of patients.
Yeah, we used a very pragmatic enrollment approach, taking people right before their clinic visit, reaching out to them via email, telephone, and then phone call. And we found that a large number of participants were willing to participate. And then we randomized them to either routine PRO assessment or usual care. With routine PRO assessment, they completed KCCQ before each of their clinic visits over the subsequent year.
All their visits?
All of their clinic visits to the heart failure clinic.
Oh, to the heart failure?
Yeah.
Okay.
And then those results were visible to the treating clinician. They were visible to the treating clinician in 3 different ways. One is the clinicians were all taught that they could add a dot phrase to their notes, and the notes would self-populate with both the question responses as well as the KCQ scores over time. There were epic summary tables and graphs where the clinician could review the results. And before the first visit, we actually handed the clinicians a paper readout with the results.
In person?
In person.
Who did that?
We had the clinic receptionist actually print them out and add them to the vital sheet that the clinician got at the time of that visit.
So even if it's a patient that you don't know, that you've never seen before, they would get the sheet.
Yep.
Okay.
And all of this was happening around the time of COVID, so there was a non-trivial amount of virtual visits, and for those, we would actually securely email the results to the clinician before the visit.
Before, okay, so they would have it by the time that they had whatever teleconference. Was there a lot of teleconferencing during that time?
There was a substantial amount that kind of reduced over time, less than half of the visits, probably about somewhere around a quarter of the visits were via televisit initially. And then in the usual care arm, we completed a baseline KCCQ and another one at 1 year, but those results were not visible to the treating clinician.
But the study team saw it?
But the study team recorded those, yep. And
when you say KCCQ, which one? The standard one that we've been filling out, the one that takes 8 minutes to fill out, that one?
No, we use the abbreviated Kansas City Cardiomyopathy Questionnaire 12. So it abbreviates the full long 23 question version to the 12 questions to try to make it something that's more manageable to complete every single visit.
So tell the audience what kind of scores. There's functional score, there's, one total score. What are the scores in this 12 abbreviated?
So the 12 question PRO captures patients' physical limitations, symptom frequency, quality of life, and social limitations related to heart failure. From that, you get 4 domain scores that, as you know, range from 0 to 100, with 100 meaning very high health status, perfect, and 0 indicating very poor health status. And then they average for the overall summary score.
So your overall summary score that you would present would be the average of all those 4 pieces?
Yeah, we would give clinicians both the individual responses to each question, and then we would give them what the patient's domain scores and then the overall summary score.
How do those scores compare with the regular 23 questions? So is 40-40 and 50-50?
Yeah, Dr. Spertus and his team had done some earlier validation work that showed that there was a pretty close correlation between the scores. So
you'd have to learn a new scale.
It's pretty similar conventional threshold. Scores of somewhere over 80 is kind of consistent with class 1, scores of 60 to 80 for class 2, and scores of kind of less than 60 consistent with class 3 or class 4.
Okay, good. So keep going. That's very interesting.
The results that we presented previously at AHA, we assessed clinicians' understanding of their patient's health status, and we compared the accuracy of clinician assessment of health status when they had the KCCQ-12 or they didn't. And we also surveyed patients to see how they felt about their clinician's understanding of their health status.
That's an interesting question.
So that's what we presented previously at AHA. And then today what we were able to present is the 1-year results, where we actually compared the clinical outcomes, with the primary outcome being the KCCQ-12 in both arms, and secondary outcomes related to the individual domains of the KCCQ-12, medical treatment rates, testing rates, clinic frequency, hospital.
And the blinding continued for the full year for the group that got randomized to not seeing them?
Yep. The usual care arm didn't actually complete repeat KCCQ-12s until 1 year, and their clinician never got to view them until after that 1 year point.
Okay. So true blinding. So what did you find?
What we presented was that there was no significant difference in the KCCQ-12 at 1 year. Overall, there was also no significant difference in kind of our pre-specified subgroup analyses, and there was very little and no statistically significant difference in medication rates, testing rates, clinic visit frequency, or hospitalizations. We did do a couple of informative, I think, post-hoc exploratory analyses. One of them was stratifying patients based on their baseline KCCQ-12. This was a relatively less symptomatic cohort than most heart failure cohorts. Our median KCCQ-12 score was 82. So that's a much less symptomatic cohort than I think we often.
The median in our clinics are 40s and 50s, which is where the patients live.
Yeah.
And 80s is a little too high. What do you attribute that to, that it's not comparable to what other literature we've had of patients with heart failure?
Yeah, I think it's related to a few different factors. One is, despite us being a heart failure clinic, we do see a broad spectrum of heart failure. We're not only seeing our advanced heart failure patients in our clinic. We see a lot of patients with HFpEF that's relatively mild, and I think milder heart failure is one component. The second component to that is that we included clinics that treat patients with inherited cardiomyopathies. So there were some patients that likely had genetic mutations, had a cardiomyopathy, but might not have actually developed heart failure yet. And then finally, I think there might be some impact on the population that was selected.
They wanted to be in a study.
Getting to those exploratory analyses, we found that the treatment effect did vary based on the baseline KCCQ-12. For the least symptomatic patients over 80 and the most symptomatic patients with scores of less than 60, there wasn't a treatment benefit, but there was a significant interaction with some evidence of treatment benefit for that 60 to 80 group, which I think might be the ones where there's more uncertainty about how symptomatic they were.
Yeah, they're in the middle kind of thing. Yeah.
And then I think maybe the most important exploratory results we have is after the study, we also surveyed our clinicians. We rolled this out across 17 clinicians, and we basically asked them, how much did you actually review the results? Did you incorporate this into your decision-making? Did you discuss this with patients? And then we stratified the clinicians based on the median response. And we saw, maybe unsurprising, the clinicians that said that they used the data more had a larger treatment effect than those that didn't.
What do we have to do to get clinicians to pay attention to PROs in the clinic? I know that I've been wanting to start it in where I am now. They'll let me do it, but it's not like they're really curious or interested. It's sort of a piece of the clinical practice that just doesn't get talked about.
Yeah, phenomenal question. I think we have to make it a little bit easier for clinicians to review the data. I think we also have to make it easier for patients to enter the data. We're now kind of expanded to routine collection across our whole clinic. We've had to really iterate on how we collect this data to get our completion rates up to 60%, but we're continuing to explore ways that we can continue to push how we can get higher completion rates, because I think the clinician has to get into the practice that these results are always available. I think that's a big limitation of the trial with patient-level consent and randomization, that you're not able to fully, adapt and incorporate into your practice. I think the other thing we saw with our trial was often clinicians grew to really like it once they got used to using it. But it's really, how do you get them to first give it a try? There were individuals in our clinic who didn't necessarily think that it would be that useful, but then they found that it, ended up finding disconnection between how they thought their patient was doing and how the patient reported, or it made the visit more efficient because they knew walking into the clinic visit, what am I going to have to really focus on with this patient? So I think we saw a lot of people that probably initially didn't really believe, and now they use it quite routinely in their clinics.
You have a lot of papers to write. Just to give you a story at HF Action, which was the first very large randomized trial that we actually incorporated the KCCQ, we were giving several instruments to fill out, not just the KCCQ. And I've timed it. It takes 8 minutes to fill out. And we gave several things like the DAISY activity index and all that. But we put it on a clipboard and it was handed to the patient by the clerks in the front. They never had seen us. They had nothing to do with us. So it was totally, as unbiased as could possibly be. And those are the scores that we used. And how I have used it in my clinic is I know their ejection fractions. I know their NT-proBNPs. I want to know who they really are. Emotionally, psychologically, their quality of life, their function. And so that's how I use that numbers to really identify my population. And they're in the 50s. And a lot of them are in the 40s, which is just a terrible number to be in. So I do urge you to try to parse some of those out and see. So what are you going to do next? What's next?
I think what I'm really excited about is we focused a lot on how we can implement this on the clinician side, how we can convince clinicians to use it and incorporate their practice. I'm really excited about the flip side of how can we use PROs to engage the patient, to potentially have the patient tracking their own health status, both as a means of remote monitoring, but also as a means of engaging them in their care when they come to the visit. I still think, one of the most seminal trials we've seen in the heart failure world recently is the EPIC-HF trial that Dr. Allen led. Is there a way to take similar principles, have patients track their KCQ, and use that to inform the conversation? So I
would
think
give them an ejection fraction, an NT-proBNP, and the score. These are 3 items that they, it's like the hemoglobin A1C of heart failure, similar to diabetes, and they know where they fit when their hemoglobin A1C is high.
Exactly. I want my patients to come into clinic not necessarily just asking, can we do another echo? Like, what's my ejection fraction change to? But saying, hey, look at how much better I'm doing in terms of how I feel.
It's a very interesting use of it. I've never thought of it in that reverse, but that's fascinating. We'll be looking forward to more publications and more studies. Thank you for being here today.
Thank you very much for having me.
Thank you today for joining us from the ACC. I hope this starts to get you thinking about the patient's perception of their disease rather than us always telling them what they feel or what they should be feeling. So we hope this helps you clinically with your own patients. This is Ileana signing off today from the ACC in Atlanta. Thank you for joining me.